Alterations in reproduction, breast disorders. The female breast is considered a part of the reproductive system. It does respond to hormonal cycles and its primary function is going to be lactation. Breast disorder signs and symptoms include tenderness or pain, a mass, discharge from the nipples, and change in the breast appearance. A breast abscess is going to be a localized collection of pus in the breast tissue. Complications of postpartum mastitis, particularly Staphylococcus aureus, might be the culprit. Symptoms of mastitis include purulent nipple drainage. It can also be some redness and tenderness, warmth to an area of the breast. These clients may require hospitalization if it is significant enough, or contact isolation depending on what bugs it is growing out. They may require IV antibiotics or oral antibiotics, and again, depending on the severity, may require an incision and drainage or IND of the abscess. Nurses need to teach wound care, teach elevation of the arm, encourage no shaving of under the arm until the wound is healed, and assist with pumping of the breast as necessary. Now, a cyst is going to be usually benign, and it's exacerbated by caffeine and nicotine, but we see it mostly in women that are 30 to 50 years old. What happens is there's going to be an area that might be tender or painful. There might be one or multiple lumps in the breast. May also complain of some mastalgia, so some discomfort. There definitely will be a hormonal influence that's more noticeable just before menstruation. So basically, these women are finding lumps in their breast, whether it is through mammography or self-breast exam, but they are benign lumps. We can also do cytologic examinations where we actually excise or biopsy a portion or the entire cyst. We can also do ultrasound sometimes to locate these. We're going to treat with analgesics, oral contraceptives, removal of that cyst, and depending on the extent of the size and discomfort of the cyst, we may even do a mastectomy. Nurses need to encourage the woman, let her know that usually the cysts will resolve with menopause, and provide emotional support. Sometimes even some cool compresses are going to feel very soothing. So, true or false? Fibrocystic breast disease occurs in women of late adolescence to young adulthood. Remember, this is false. Age 30 to 50 years of age is when we typically see those fibrocysts. A fibroadenoma is a solid benign breast mass of connective and glandular tissue. It does have a hormonal influence. Usually it's just a single nodule and has no change with the menstrual cycle. This is often seen in late adolescence to early adulthood. These women will have that painless, non-tender lump that's encapsulated. It's mobile, in other words, you can move it around, and it's firm. We diagnose with ultrasound and excisional biopsy. Sometimes we'll just observe this, but other times we will excise it or remove the tumor itself. Again, if it's removed, nurses need to educate on wound care. Also educate on breast self-examination and the administration of mild analgesics. Breast cancer is going to be a mass of abnormal cells. Risk factors, there's a lot of them, but the two main ones are being female, because men can also have breast cancer, and being over 50 years of age. However, there are some other things such as a defective gene, hormone replacement therapy link. It does affect 1 in 8 women. Caucasian women are at a higher risk, but actually more African American women will die from it. These clients often will have a painless mass in the breast. They may have bloody discharge from the nipple or dimpling of the skin. They may have nipple retraction. They can have an asymmetrical breast shape or size, or have what we call orange peel skin. We diagnose once again through mammography and biopsy. It may be located through that breast exam. However, we will talk more about that in class. Treatment will depend on the tumor staging. It also depends on the overall health of the female or male, and also will depend on the type of cells. We may encourage surgery, chemotherapy, radiation, or immunotherapy. Now, some of those drugs that we may administer, some of those cancer drugs, we refer to them as cytotoxic agents. They are indicated for solid tumors and some hematologic malignancies. Adverse effects, of course, include that hair loss, nausea, vomiting, and myelosuppression. Because if you recall, those drugs are going to target the fast-growing cells. The fast-growing cells are going to be like your hair, your nails, the lining of the gastrointestinal system, and your blood cells. It can interact with other chemotherapeutic drugs, radiation therapy, or digoxin, causing toxicities. So a couple of these drugs might be your doxorubicin and your mitoxantrone. Hormonal agents, again, are sometimes used during the treatment of breast cancers. A variety of neoplasms, and it's frequently used as a palliative or adjuvant therapy. It does also suppress bone marrow and may lead to pulmonary fibrosis, nephrotoxicity, in other words, toxicity of the kidneys, neurotoxicity, hemorrhagic cystitis, cardiovascular toxicity, nausea, vomiting, acne, growth of hair, gynecomastia, especially in the men, the breasts will enlarge, headache, hypotension or hypertension, and bradycardia. Very important that we handle these drugs with care because they are carcinogenic, they're mutagenic, and teratogenic. So in other words, they are very harmful to a developing fetus. We also need to teach infection prevention and monitor these women closely. Some of the BRMs, or biologic response modifiers, they're used to alter the body's response to diseases such as cancer. They're also autoimmune, inflammatory, and infectious diseases are what they treat. They can enhance or restrict that immune response, stimulate hematopoietic function, prevent disease or inhibit metastasis, prevent cell division, or inhibit cell maturation. It can be classified according to the biologic effect, whether it's hematopoietic or immunomodulating. Subclasses of the immunomodulating drugs will include those interferons, monoclonal antibodies, interleukin receptor agonists, and antagonists. These BRMs can also include the DMARDs, those disease-modifying anti-rheumatic drugs that treat rheumatoid arthritis, such as methotrexate. Excuse me. And then targeted drugs that recognize a specific molecule that's involved in the growth of cancer cells, while mostly sparing those healthy cells. Those include those monoclonal antibodies and the tyrosine kinase inhibitors, or TKIs. Those indications would be for lung, breast, thyroid, and renal cancers, along with leukemia and lymphoma. And of course, we need to include the medications that we might use for nausea and vomiting that's associated with chemotherapy, such as those serotonin antagonists. They can also be used to help prevent postoperative or radiation nausea and vomiting. Those drugs would be like your ondansetron specifically, and there's a few others. We also might use the dopamine antagonists. They are also antipsychotics, but are very good at helping prevent nausea and vomiting. Unfortunately, they do have side effects of orthostatic hypotension, tachycardia, dry eyes. So if it's going to start drying things up, that means we're going to have urinary retention, constipation. These drugs can also cause that tardive dyskinesia, the headache, those extrapyramidal symptoms that kind of mimic the symptoms of Parkinson's. The main drug in this classification that we look at is promethazine. Its trade name is Phenergan. And then we also look at our cannabinoids. They are very good at treating nausea and vomiting associated with chemotherapy, and also can stimulate the appetite for those that are having issues with decreased appetite, weight loss due to the chemotherapy. Adverse effects do include that drowsiness, dizziness, confusion, anxiety, euphoria, visual disturbances, and dry mouth. Okay, so in treating the breast cancer, we can do the lumpectomy, where we only remove the tumor itself. We can do a partial or segmental mastectomy, where the tumor and some breast tissue in the lymph nodes are removed. We can do a simple or total mastectomy, where all of the breast tissue is removed. A subcutaneous mastectomy will remove all of the breast tissue, but we do leave the skin and nipple. We can do a modified radical mastectomy, where we remove the breast, some of the lymph nodes, especially in the axillary area, the chest muscle lining, and the pectoralis minor muscle is removed. The radical mastectomy removes all of that, but it also removes the major pectoralis muscle. So, criteria for the mastectomy choice: the surgery will be performed immediately after obtaining the results of the biopsy or shortly thereafter. The type of surgery recommended will depend on the stage of the tumor and the client's informed decision about treatment options. The current trend is to perform the least disfiguring procedure necessary to obtain that favorable prognosis. Complications postoperatively, especially with the modified radical mastectomy and the radical mastectomy, is going to be lymphedema because we do remove those lymph nodes. So in other words, we're no longer draining that lymph fluid the way we're supposed to. So nurses need to prepare for treatment and postoperative concerns. We need to encourage postoperative arm exercises, encourage that compression sleeve, the prostheses education. We do no injections, no blood pressures, and no IV sticks in that affected arm. The client should also be instructed not to sleep on that affected side. We should also encourage limited weight lifting with that affected arm. And the client needs to not only protect that arm, but protect the hand. So when they're doing something that may cause injury to the hand, such as gardening, something as simple as pulling weeds where they can get splinters or thorns stuck in their hand, they need to be wearing gloves. We should also connect the client with resources such as Reach for Recovery. This involves a group of women who are breast cancer survivors themselves that come and actually work one-on-one with these women. They teach them the exercises, they provide group meetings, they help walk them through this trauma. Prostheses choices, etc. So question, true or false? Breast cancer is staged, with stage 1 being the most advanced. And we know this is false. We know that stage 1 is going to be the least advanced. Stage 4 is going to be the most advanced, and this is where we have metastasis. Okay, metastatic breast cancer is the migration of those cancer cells to another part of the body, spread by direct extension. We often see it in the lymphatics, the bloodstream, cerebrospinal fluid, lymph nodes. It can go to the bone, to the pulmonary system, the brain, the adrenals, and the liver are the most common sites. These clients will have pain. They may have pathologic fractures if it has extended to the bone itself. We diagnose with X-rays, MRI, CT scans, and lymph node dissection. These women may just require palliative treatment, intramuscular androgen therapy, or radiation therapy. We want to encourage these women to reach out, ask questions. We're going to provide supportive care. Prevention with increased risk of these women, they need to have long-term follow-up. Bilateral prophylactic mastectomy is also a potential preventative in these women that may be identified with the appropriate DNA markers. Chemoprevention with some cancers may be done with tamoxifen, raloxifene, and NSAIDs. And the dietary impact as for prevention of breast cancer really is non-conclusive. Some cosmetic breast procedures include breast reconstruction, where we refashion an area of a mastectomy to stimulate the breast contour. It can be done at the same time as the mastectomy or at a later date. Optional, we can leave the nipple and the areola, which help with that reconstruction. We can do artificial implants such as the saline filled. There's still the silicone gel out there, although there's high complication rates with that. And need to make sure that those are FDA approved. We can also use normal tissue for a natural look and feel. Some women have such large breasts that they want to do a reduction mammoplasty. Clients that have a D cup or larger with their bra are those that are going to be most eligible for that. This is an overnight surgical procedure. We can also do an opposite breast reduction that corrects asymmetry. It reduces a healthy breast to resemble the size of a reconstructed breast. It's similar to a mammoplasty. A breast lift is a mastopexy, which corrects sagging or low nipple placement. A breast augmentation is actually enlarging the breast using usually a saline implant because of the high risk with the silicone implants. Nursing management includes preoperative and postoperative care. Encourage these women to sit in the semi-Fowler's position because once again, elevation helps reduce edema and also manage their pain. We need to teach these women to continue to have mammograms, do the breast self-examination, wear a well-supporting bra, and exercise.